Welcome back to another episode of The Learning Curve. This is the podcast where we explore the educators and ideas reshaping medical training. Imagine this scenario. You're scanning the ED board when you see it. A familiar name, a familiar complaint, the same patient back again. Before you open the chart, the questions start pondering through your mind. What did I miss? What changed? What is this case trying to teach me? In emergency medicine, we call these bouncebacks, and they're some of the most uncomfortable moments in our practice. They trigger anxiety, self-doubt, and some defensiveness. But they also hold some of the richest lessons that we have. Because again, bouncebacks aren't just repeat visits. They're mirrors reflecting our cognitive habits, communication gaps, and system pressures as well as blind spots. In today's episode, we're going to be exploring why bouncebacks happen more often than we think, how cognitive biases shape these cases, and how to reframe them from blame into powerful teaching moments. Joining me today is the legendary Dr. Michael Weinstock. He is an emergency physician, educator, risk management editor for MRAP, as well as the co-host for UC Max, as well as the author of the well-known Bounceback series. His work has shaped generations of clinicians see return visits not as failures, but as feedback. Because again, bouncebacks aren't failures, they're feedback, and today we're going to learn how to listen. Mike, thank you so much for joining me today. I really appreciate your time.
I can't tell you how excited I am to be here. It's an honor. Thank you so much for having me.
Yeah, definitely. And I think, again, this is going to be such a fun topic because it's almost like a blind spot in medical education where quite often we teach residents and medical students on how to deliver safe care, but sometimes we tend to forget about helping them develop the mindset that can really help set them up for success. So to start this conversation, Mike, I want to ask you this. You've reviewed and written about thousands of bounce back cases. When you zoom out across all of them, are there particular patterns that jump out to you most often, and which ones still tend to surprise you?
Yeah, absolutely. And one of the most important things to talk about is just because a patient bounces back doesn't mean that something wrong was done. And just because we don't make the correct diagnosis initially doesn't mean, ethically, but also legally, that something wrong was done. So that's really important to think about. Maybe 3 to 8%, and depending on different studies, of patients will bounce back. And a lot of times we want those patients to bounce back, right? So for example, a patient with ureteral colic, right? They have ureterolithiasis and we think we've controlled their pain, but their pain maybe at home is not able to be controlled with oral medication. We want them to bounce back. We can then, whatever we're going to do for them in the hospital, like IV medications, maybe a stent, whatever might happen to be. So all that stuff is great, right? In the same way, when you think about patients who bounce back, we also want to think of ourselves, and we shouldn't feel shame. We shouldn't have that type of consideration that we're having imposter syndrome because we had a patient bounce back. That phrase, remember the patient you saw last Tuesday,
Yep.
right? Shouldn't be something that strikes fear, although it probably does, right? But it shouldn't necessarily be something, because in some ways we want patients to come back because they might have a disease process that's very early in the course. So they have some generalized or minimal abdominal pain, some nausea. And then, of course, 12 hours later, my neighbor can diagnose acute appendicitis because now it's localized in the right lower quadrant.
Yeah, and I think that's actually a really great point because I think quite often we tend to look at it from the lens of blame and anxiety, where just that even phrase that, hey, do you remember that patient that you saw a week ago? You're like, oh my God, what did I miss? But no, I think that's actually a fantastic overview. So Mike, when you hear the word bounce back, a lot of clinicians automatically assume that, hey, this is a misdiagnosis. But in your experience, how often is it really a cognitive issue versus a system issue? And how do those two concepts usually interact?
So when you think of the data that we see based on if that bounce back was due to some type of error with that initial visit, it's a little tough. And sometimes we need to adjudicate with multiple clinicians who will look at that. But then we're also prone to our own bias, right? Because we know that patient has bounced back. So this type of study is pretty difficult to do. A study that I quote pretty frequently is the one by David Sklar that was in Annals of Emergency Medicine. And they looked at 387,000 patients over a time span of 10 years. And they looked at patients who died within 7 days. So that's the timeline for most of these bounce back mortality studies. And what they found, and I think a lot of the listeners will be aware of this study also, is that they found 35 what they identified as possible error cases. In other words, something that could have been done at that initial visit that would have possibly prevented that bounce back death. And interestingly, myself as the PI, and through our institution, some other researchers also nationally, including David Sklar, are reproducing that study in a little bit of a different way. So more on that. Hopefully, as now we have the data, we have IRB approval, we're just incorporating that and getting that written up. So it's sort of exciting to think about that, looking not only at what David Sklar found, which was that of the patients that bounced back, that those 35 patients, which was 1 in 11,000, that 71% of those patients had a unexplained tachycardia.
Mm.
And that was one of the common themes. Now, there are some other themes that they found also. You can just read through the study yourself, of course, anybody that's interested in more information on that. But 71% unexplained tachycardia, a full 85% abnormal vital signs. Sometimes this is a system issue, right? A patient is sent home. Maybe they don't have ability to care for themselves at home. Maybe they weren't able to follow up primary care, just for example. But sometimes it is some type of cognitive error. And when we look back, you asked me this question before, the biggest fallout is the history of present illness. And we can talk about this a little bit more. It's one of the big interests of mine. But when you think about the chief complaint, for example, chest pain, right? Well, I think of ACS PE dissection as the potential etiologies of that. The data will show, and we have another study that has actually been submitted and waiting for approval with one of the more major emergency medicine journals. But when you think about the approximate numbers based on the study by Farinoff and others, about 1 in 10, maybe it's 1 in 20, say 1 in 10 of chest pain patients will have ACS, about 1 in 100 will have PE, and based on a study by Alter, about 1 in 1,000 will have dissection. So when you think to yourself, any chest pain patient you see, if you don't even go into the room and evaluate that patient, you're 99.9%
Yeah.
correct with aortic dissection. But of course, that's not good enough through the course of a career. Because the testing is different for each of those, ACS, PE, and dissection, with either, EKG troponin plus minus chest x-ray, dimer, just for example, low to moderate risk, and then a CTA for dissection, because the testing is different, until you gather appropriate data with your history of present illness, how do you even know what testing to order? And if you don't, you're just sort of hoping to get lucky that it's not one of those less likely possibilities. I'll end this by saying a phrase that maybe folks have heard me say in the past, so important. And this is one of the biggest fallouts I also see, not only with reviewing cases, but also with medical legal issues, is a good history is free, but a poor history might be very expensive. We're at the bedside. We can talk to the patient. Might as well get as much information as we can when we're seeing them initially.
Absolutely. And this is something that I've tried to work on with a lot of my interns, specifically about the history taking, because I think quite often that tends to get lost by the wayside is when residents come out and present and there's certain questions that I ask them, hey, is there any family history of heart disease or family history of sudden cardiac death? Because that might potentially cause us to think a little bit differently about this case. Because initially we might be thinking it's low risk, but then if every single male in the family has passed away at a young age, now maybe I'm looking for Brugada. I'm looking for something else that maybe potentially might be driving this. And I think your point about the discharge tachycardia is very, very important. A lot of my seniors, this is something that I echo to them that, hey, listen, you have to start building safety nets for yourself, right? So if you don't have an explanation for why this patient's tachycardic, you really should do a cognitive pause, reassess, ask yourself, hey, is there something else that I might be missing? Because again, that's your last chance before they end up leaving your department to really try to ascertain exactly as to kind of what's driving all this.
And echoing what you're saying, that doesn't necessarily mean you need to order all kinds of extra labs or
Yep.
you need to order all kinds of imaging. It might be just a matter of a reassessment, going back and talking to the patient again. Maybe other family has arrived. Maybe you're repeating that abdominal exam. Maybe you're confirming the history. And I know that I don't even have to ask you about this, but I'm sure you've had your handle on the door, right? Leaving the room and, you've confirmed there's no chest pain. And then the patient says, but what about this elephant sitting on my chest? That's probably the reason why you and I'm sure also as students, maybe even as residents, had a situation where we got history and then the attending got a different history. But maybe what's differentiating us now is that we're confirming that history. I do that all the time. And I'll even put that in my documentation. Another really big teaching point for our discussion here is it's good to say the patient has constant chest pain for the last 5 hours. It's better to say, I confirmed twice the patient has had constant chest pain for the last 5 hours, and at no point did it completely resolve. To me, that's a one troponin type of evaluation. Maybe folks do 1 or 2 EKGs. All those things are good. I do that sometimes also. But making sure that we get that information in our documentation is so important, because later, if there is a bounce back or an adverse outcome, no one wants to be guessing as to what transpired when you saw that patient.
Yep. Because then again, your documentation's clear and you're
Yes,
very clear with specifically what you saw in that moment. Mike, are
absolutely.
there any other predictable patterns that bounce back follow, specifically things like anchoring or failure to deliver or ensure follow-up? Is there anything else that you've come across that tends to become a very common theme?
One thing that I would caution all of us on is the diagnosis momentum that we talked about, where a previous diagnosis, maybe from primary care or initial ED visit, just for example, becomes established. But even more so when the patient thinks they have their own diagnosis. And I talk sometimes about the case of Jonathan Larson, who was the writer of the musical Rent, the longest running musical in the history of Broadway. And he went to 2 different New York emergency departments, first being diagnosed with food poisoning and then with gastroenteritis, before he eventually died of, unfortunately, aortic dissection. But at that initial visit, the documentation in the record was that he had eaten a bad turkey sandwich, which I'm sure played into the emergency physician's diagnosis of food poisoning. He told us that because that's what he wanted it to be, because in the end, of course, no one wants to have ACS, PE, or dissection, of course, right? And I've had patients, and this is a little bit of a funny story, maybe it's not necessarily mean-spirited, but all of us have had this kind of patient. When I said to this patient who had chest pain, "Have you had any sweating?" He says, "Yes, but it was warm in the room." And he shortens of breath. "Yeah, but I'm really out of shape." And I'm like, "Listen, dude, I get it. You don't want to have ACS. I don't want you to have ACS. But here's the deal. You be the patient. I'll be the doctor, right?
Yep. Yep.
Tell me the
Yep.
symptoms, then I'll try to incorporate that into something that's comprehensive. So we need to be very cautious when a patient tries to talk us into something. And I have so many cases in the Bounceback books of where that actually occurred. The family or the patient gave some type of explanation that turned out to be the diagnosis, only because not they intentionally, but their presentation led us astray in that way.
Absolutely. And this is something that I also try to echo to my residents is, ask yourself, does this patient typically come to the emergency department? And you always get that farmer that's like, hey, I haven't seen a doctor in like 25 years. I had just a little bit of chest pain while I was like, shoveling snow. Residents come out, hey, yeah, the story seems benign. No, this is not a guy that frequently comes here. He's clearly downplaying. He's probably going to need more of a thorough workup. And your threshold for badness in this patient's going to be very, very low. So you always get kind of patients like this. But I think your story really echoes to this idea of cognitive vulnerabilities that quite often as clinicians we can become trapped with. Are
Mhm.
there particular cognitive vulnerabilities that show up very consistently in bounce back cases, even amongst experienced physicians from your standpoint, Mike?
So the diagnosis momentum that we talked about, but that anchoring bias is another one that is one of the more common themes, where we anchor too early on data and we don't allow subsequently obtained superior data to interfere with that. So here's just an example. And another case from one of the Bouncebacks books is a 5-year-old, and this plays into the parent also, but this is a 5-year-old who came in with his grandmother with abdominal pain. And she said he just ate some eggs and cheese and orange juice, and I think he has food poisoning, which sort of turned out to be, the diagnosis was gastroenteritis, but close enough, right? Well, in this story, the physician very early anchored on that, and the patient, I get it, he was only 5, said, "I have no abdominal pain." Well, the subsequently obtained superior data was not only that he actually did have abdominal pain on exam, but in addition to that, had a midline scar from a previous appendectomy. And then the thought was, well, why did they not sort of get that? What was a little bit different about this case? Well, as it turned out, he'd had a ruptured appendix several months previous, which is why there was the midline scar. So that was that subsequently obtained superior data, right? He had a midline scar. He actually had abdominal pain, whereas the history, he didn't. Well, he's a 5-year-old, probably doesn't want a shot, or he's scared, right? When you get that discrepancy, go back and see that patient again. And some people have said the best utility for labs when you have abdominal pain is so you have to wait for the labs and you can go back and reassess and reexamine that patient.
Absolutely. And I think that really speaks to a lot of cognitive vulnerabilities that I think as educators, we have to start getting better at because I think sometimes for our trainees, we don't really teach them about cognitive awareness and this idea of what's happening in that moment that potentially needs to be addressed. Because I think quite often what ends up happening with younger learners is they look for a lot of confirmation bias and they're looking for things that fit what they originally thought, as opposed to stopping and asking themselves, hey, listen, does this actually fit what the patient is telling me, right? And is this consistent with my own illness script of what I perceive this disease to be, right? If a resident comes out and tells me, hey, listen, I think this patient just has gastroenteritis. And the first thing that they mention is, well, it's been going on for 7 days. Okay, well, now we have to kind of reassess, stop right there and put a safeguard on because gastroenteritis typically doesn't last for 7 days, right? This is a patient that we potentially need to do a little bit more of a workup on because, again, they're giving you information that's discordant with what your illness script for gastroenteritis is. And that's a patient that potentially we're going to have to do a little bit more of a workup. And I'm sure you've probably encountered that with your learners as well, where they tell you something and as they're presenting, you're like, okay, this doesn't sound right. Right. So how do you tackle that? What's been your approach to try to address some of these cognitive vulnerabilities?
So I have this concept of the medical decision-making note and this thought, and maybe you or the listeners have heard me talk about this in the past, is doing this hard stop as part of your MDM. And here's me after seeing over 100,000 patients, over 30 years into my career and still going strong, by the way, and still loving what I do. So it's not like I'm saying like that in a negative way. That's a very positive way. But I still hear myself, not commonly, but occasionally saying something in the voice activated dictation and think to myself, I don't know that really makes sense. So this is really an important thought that our chart, our documentation is an argument, right? It's a story and it's an argument for why the diagnoses that we think are going on, why that's reasonable and why other maybe more serious diagnoses are not occurring. And if we can't even convince ourselves, this is the concept of the hard stop, how can we convince a department chair or a family member or a jury later, right?
Yep.
So those thoughts are really, really important, that this is a story, and asking ourselves when a patient is leaving, when we're discharging a patient, if this patient does bounce back horizontal and room temperature, i.e. dead, in 48 hours, what could I have missed? And then maybe address that. I don't think this is a subarachnoid hemorrhage, not only because the documentation shows that the headache started gradually, but how did it start? It started at noon and reached maximum intensity at 4 in the afternoon. Now it's the more specific documentation, the more believable documentation. One other thing that I find that my own residents get a little confused with is this concept of triage queuing. And this is something that Pat Crosscarry, the Canadian emergency physician that came up with a lot of these cognitive biases in the academic emergency medicine article, the initial one, and then other subsequent articles that he's written. But this concept of triage queuing is that sometimes a patient will be put in the trauma room that doesn't really have a trauma. It's just because that's the only room open and we can move them out very fast if a trauma or a major medical case does come in. And I'll see a lot of stuff is ordered, or they tell me they want to order a lot of things. And I say to myself, it's like, if you had that patient in one of the fast track rooms, would you be ordering all this stuff? And the answer is no, right? Or in the same other way, and this might be even more concerning, a patient that's in a fast track room, and this is many years ago, one of my partners had a patient with a sunburn, turned out to be, a particular rash from meningococcemia. And there's many other examples. I'm sure you and I think of many of them ourselves, right? Where that got fooled. And that's the reason why it's triage, not diagnosis.
Yeah.
Why is it not called diagnosis? It's because the nurse is triaging that patient. They're sorting that patient as to, what they think that level of acuity is. But it's our job. That the nidus is on us to actually make that diagnosis. And I'll just come up with one last of these cognitive biases, is what's called the psych out bias. And that's where a patient with some sort of psychiatric illness will falsely attribute their symptoms to that. And I'll give you a story of this also. It was a guy, he was like homeless. He was like lived behind this gas station. He came in all the time. He was always like getting beat up, and it turned out to be that he was fine and we'd send him home. And one day they brought the guy in and I recognized the name and I was was like, by the squad base. So I saw him coming in and I stopped and I was like, hey, buddy, good to see you, whatever. Put my hand on his leg. It's like, ooh, that's really cold. This is in Ohio in February. And his body temperature was 79 degrees. He lived, but the thought is this, people that have psychiatric illness probably don't take their diabetes medicines as they should. They probably don't manage their blood pressure as they should. They probably don't have the access to get into the healthcare system as they should. So there's a lot of these biases. If we're aware of them and this concept of metacognition, where we are monitoring our own thought-making process, thereby realizing when it might be prone to error, wow, that's the next level of excellence in emergency medicine care.
Absolutely. And that's something that I've tried to impart on a lot of my seniors that start to moonlight. And I tell them, hey, listen, if you can develop this metacognitive process where you're pausing and asking yourself, hey, how am I actually thinking about this case? That really can take your clinical aptitude to a whole nother level, because now you're building your own internal safety checks for these patients. And I think that's actually a really, really great overview. Like, one of the things that I also wanted to pick your brain about is your Bounceback series does this really well. And that's this idea of removing shame from a lot of these cases that come back to the emergency department. How do you personally reframe a Bounceback so it becomes a learning moment instead of a source of blame?
So the first thing is, and it's not exactly to your question, but to make sure the patient understands, glad you back. It's not an annoyance. Like, you couldn't imagine running some sort of like ma and pa grocery store and saying to the customer, you're back again? You just bought milk last week. I mean, come on, man. Like, why are you bothering me with wanting to buy more milk,
I love that analogy.
It's sort of funny. I will say I can't totally take credit for it. I think it was Greg Henry that came up with that one,
Yeah.
or maybe it was Rick Bucata. But in the end, it's like just sort of funny, right? Like, the patient is coming back. And I like to think of it as them giving us another opportunity, right? Because in the end, sometimes diseases present really early in the course. So, for example, if you look at the ACEP clinical policy on chest pain, and this is from 2018 on non-ST elevation chest pain, and they specifically say that there is now a 1 or 2% acceptable miss rate. And they also say, and I love this, that trying to get lower that will cause patient harm from false positive testing as well as other problems too. So in the end, you don't want to do a CT scan on everyone for appendicitis, or a CT scan on everyone for subarachnoid hemorrhage, or all these other things. And we just need to realize that things might present early in the course. So that's for the patient. But for us, it's really, really important. And when you think about something like either peer review or an M&M conference, is to have this culture of a safe space, right? That this is for learning. And I love Weirs and Nemeth, who are two researchers, and they published an article and they talk about this thought of how we think about bounce back cases. And they say, and I love this, they say that we learned somewhat from bounce back cases when we think about how they framed a question, how that turned out to be wrong. But when we really learn is when we think about how that framing seemed so reasonable at the time to that emergency physician or clinician. And it's only by thinking of it in that way do we understand the opportunity, and using my own words, to go from something like standard of care to excellence in care.
I love that. And I think that's something that I've tried to reframe through some of the conversations that I have with some of my younger learners. Is automatically they're trying to look at it from a lens of anxiety, blame, that, hey, look, this happened. But I think if we reframe that conversation to focus on the actual process as opposed to a blame game, I think that tends to be a lot more valuable. And again, some of this also stems on us as educators, where we have to have a certain level of modeling humility where, we're saying, hey, we're not perfect clinicians. We're going to have our misses, but what can we actually learn from this? And again, I think that's probably the way to go in the future so that we can help our learners really understand that, these things happen. I also try to make it into almost like a little bit of a narrative, because that tends to, again, separate the person from the actual decision. And if you can reconstruct that story, that can help us also understand some cognitive pitfalls that can happen. And in that storytelling, I like to create these certain stop points. And I say, hey, so at this point in time, would you have done anything different in terms of your management, right? Would you have focused on the tachycardia at this point in time? Or did the tachycardia not get picked up because of, let's say, the vitals weren't checked or something else along those lines, where there are system issues that contributed to this problem? Because again, I think that conversation can then become more robust and really help our learners. Now, Mike, one of the things that I was wanted to pick your brain about is that for departments that really want to do this better, what, in your opinion, separates programs that truly learn from bounce backs versus programs that are unintentionally potentially creating fear around them?
So when I became the department chair at the previous job that I had in 2013 for almost 5 years, one thing that I set as a criteria is that I'm going to assume that my emergency physicians are correct, that they made the correct diagnosis, that they treated the patient kindly until you prove to me that they did not, as opposed to some of the previous chairs, I'll say, where it was sort of the blame was on us. Prove to me that you did treat this patient kindly. And when you think about the ability to sustain a career in medicine or in emergency medicine, right? I think of two words. I think of competence and confidence, because this sense of purpose that we all have going through our lives is in some ways the same way as going through our careers. We spend such a large amount of our waking hours at our career during our productive years, right? Hopefully that's going to span quite a long period of time, right? That we have to have that sense of purpose. We have to feel that we're good at what we're doing. And we also have to feel that we are making a difference for the patient. You'd never want, for example, one of your residents or maybe a PA or NP or one of your colleagues, right, to not ask a question because they felt like it's a dumb question
Yeah.
or that is something that's going to get in the way. And we had a case, this is some number of years ago, and this is sort of a weird story, but one of the cases from the Bounceback book is from the medical legal book was a patient who came to the ED with a headache, diagnosis momentum, re-diagnosed with sinusitis, antibiotic was changed, had a CAT scan of her brain, came back negative, sent home. Well, it turns out that she was a postpartum patient. She went home and had a seizure,
Mm.
came back. This physician hadn't heard of this diagnosis, postpartum preeclampsia, right? And so they ended up admitting the patient after she had the seizure, and then things went bad to worse and ended up with called triplegia. So like it's not quadriplegia, it was three extremities, which maybe everybody knows that term. I hadn't really heard it listed that way until I was sort of became familiar with this case. But anyway, the short version is that this patient had a terrible outcome because this physician hadn't heard of this diagnosis. Do we need to know every single diagnosis? We can't, right? I mean, there's so much in medicine.
Yeah.
But what we can know is, I think what you were alluding to just a few minutes ago, is when something doesn't feel right. And you talked about the patient who had gastroenteritis for 7 days. It just doesn't feel right. Is this a special population patient? Is it a chemotherapy patient who has a fever or altered consciousness? Is it a patient with necrotizing fasciitis who has that labellin difference, that encephalopathy from that metabolic acidosis or, lactic acidosis type of process that's
Yeah.
occurring? They just aren't answering questions exactly right. They might know the month, they might know the year, they are learning times three, but you know what? You wouldn't want them driving your kids to preschool.
Yeah.
So sometimes it is that sixth sense that we just pick up on.
Yeah.
And that's the thing that separates, I think, an excellent clinician and allows all of us to go from what I just said a few minutes ago, standard of care to excellence in care.
This is going to sound really funny, but I try. This is not like an academic thing, but in order to try to relate to some of my younger learners, because I've realized that every single year I get older and older, so I have to try to kind of relate to them on some level so that I can, connect with them, especially on cases like this. One of the words that I've started to use is, "Hey, does this patient meet the vibe check? Do they have good vibes? Like, does this actually make sense?" And that's something that has kind of been another one of the safety nets that I've started to build for some of the learners, where they come out of the room. Same thing with the gastroenteritis. The vibes aren't right here. Gastroenteritis should not be for 8 days. Let's go do a travel history. Let's ask about chemotherapy. Let's ask about other, immunocompromising conditions that could be maybe driving all this. So we got to definitely make sure the vibes are right before we move on with this case. So I love that.
So there's a lecture, just interrupt that for a second. I want to piggyback on that,
Yeah.
what you said, because I love that thought process. Is a lecture that I give called How to Spot the Well-Appearing Patient Who Will Soon Be Dead. The title is long, but it's catchy, right?
Yep.
And one of the thoughts within that lecture is of all the patients we see every day. I mean, just say, for example, you see 2.5 an hour. You work for 10 hours, see 25 patients. Well, you can admit about 20%, so maybe 5 or maybe 6 patients. And then there'll be a number of patients that you're pretty confident when you send them home. There might only be several patients that have one of two things, which are diagnostic uncertainty about a potentially life-ending diagnosis or abnormal vital signs that weren't addressed. So it's not only just tachycardia, we talked about that's super important, but also tachypnea, which might in the end even be more specific than tachycardia. So when you think about your whole day, like how can I go in and have this long note on every single patient? You've probably heard the expression, which I don't love. If it wasn't documented, it wasn't done. Because in the end, here's the deal. We are documentarians. We are historians. We are not transcriptionists. And
Yep.
so just because we don't put it down on paper doesn't mean it wasn't done. We just mean that as part of that history, that we didn't feel that was important. Some of that nebulous kind of stuff, just like you talked about, it doesn't meet the vibe check, right? Can be something that we don't put down on paper. And one of the other cases in one of the Bounceback's books is a 42-year-old man with shoulder pain, came in diagnosed with the shoulder strain, sent home. But here's the weird thing about this. After he eventually came back around 12 hours later with not just necrotizing fasciitis, but necrotizing myositis, and then died 2 weeks later from that. When they left the emergency department, they stopped on the way to the pharmacy. He and his wife, she was driving to get gas. She got out and pumped the gas. He got out, pulled down his pants, and urinated on the gas pump. He had that labile indifference we talked about just a few minutes ago. Well, was that something present when they left the ED 15 minutes earlier? Absolutely it was. Was that picked up on? Maybe, maybe not, right? But thinking about some of that alert-oriented times 3, but we're not airline pilots, right? We don't have objective instruments. We're dealing with the human condition. And as part of that, again, separating that excellence is when we can really think about when things just don't pass that sniff test, just like you
Yep.
said, or the vibe test, however you want to say
I like the sniff test too. That's something that I used to use, but now with
it.
these newer Gen Z kids, I'm like, okay, we'll use the vibe checks.
Maybe not in the ER, the sniff test. Maybe that's not the best thing in the ER, right?
I love that. So, Mike, are there specific tools, questions, or frameworks that you historically have found yourself coming back to when you're starting to dissect these bounce back cases with learners?
Yeah. And so I talk about a concept of the 3 R's, and you won't really hear this otherwise, but that's part also of that lecture, How to Spot the Well-Appearing Patient Who Will Soon Be Dead. And I think about revisit, record, and recruit. So when I talk to the learners, I say, look, the obvious cases that are benign, corneal abrasions, ankle sprains, the obvious cases that are concerning, through the windshield, down the highway, no one's sending that patient home with a Z-Pack, right? But the cases where you might think about that patient on the way home, because again, I don't know you that well, but I'm guessing when you leave the shift and are going home, you want to be thinking about home, not about what you just did. You want to be thinking of the future, right? Whatever you do when you get home, right? In the same way, I think about any patient that I would potentially worry about on the way home. I want to do those 3 R's. And just briefly, revisit is go back and see that patient again. Are there progression of symptoms? Did I get all the data that I initially needed? Are there other family members who are there that could shed additional light on things? Record. We talked about the concept of that hard stop in your medical decision making. So making sure that I have obtained appropriate data. It's astounding to me with the almost 150 medical legal cases that I've done that so frequently the history is lacking any consideration of more serious things such as ACSPE dissection. I mean, if a patient comes in with chest pain, what they're asking, their presentation is asking maybe something a little different, but their question is, am I having a heart attack? My neighbor, whoever, right, that comes in, right? Well, their presentation, though, is asking to you and me, is this ACSPE dissection? And how can you have a patient with chest pain where you don't even ask them if it's exertional or if it's pleuritic for PE or if it radiates the back for dissection, right? But so frequently, I see a history that's merely a restatement of the chief complaint. And that's not the care that we'd want for a family member. So revisit, record, and then recruit. And the recruit part is very, very important because it's not only recruiting a family member to help, it's also recruiting the patient to help monitor their own condition for symptoms that might change, that might progress, or that don't resolve, right? So the gastroenteritis that doesn't resolve in 7 days, well, maybe now their vomiting and their headache, and that's present only in the morning and resolves when they go to work from something like carbon monoxide toxicity, right?
Hmm.
Or maybe that recruiting is a family member that's going to be able to watch a person who is pre-verbal or who has dementia or some other cognitive problem, and that they understand a very, very important concept, which is the concept of diagnostic uncertainty when a patient leaves the ED, because that's okay. It's okay if we have some diagnostic uncertainty, but that next level of trying to get it right. And I think this was Steve Clucciello, it might have been Amal Mattu, who said that, you know, the discharge instructions are the last chance to get it right.
Yeah.
And when I think of just one other concept, maybe a big take home point from our discussion here is not only putting in your documentation, I discussed this with the patient. You could talk in medical decision making. They understand that we haven't completely excluded acute coronary syndrome. We think it's really unlikely, but they do agree to return at this level and to follow up at this time span. But then to put that in your discharge instructions also. Preface it with this very simple and easy phrase. As we discussed, we have not completely excluded heart attack, ACS, whatever the patient would understand. Right? And we do feel that it's safe to further continue your evaluation as an outpatient, but please return with worsened symptoms, longer symptoms, symptoms that don't resolve those different things, diaphoresis, associated dyspnea, etc. So those 3 R's are a very, very important concept that can help us to get it right when there is a unusual or very in the course of their disease process presentation.
I love that. And I honestly, that last R I think is so, so important.
Mm.
And this is something that I try to echo to a lot of my learners that, hey, listen, when you go back in that room to discharge that patient, that is your last chance to give them the right return precautions, the right follow-up care, and really sit down and just walk through that. Because if you have those return precaution scripts built up, you can really set your patients up for success. Hey, the emergency department right now, our workup is for the most part unremarkable, but that doesn't mean there's nothing going on, right? Ultimately, this is a picture, it's a snapshot in time where things can potentially change. And if, let's say, you have XYZ symptom or an exacerbation of your symptoms, I want you to come back here. Right. And that basically sets your patient up for success because we can't expect them to know what to watch out for. Right. You have to be able to educate them, to be able to give them the guidance that they need to be able to say, hey, this is something that the doctor told me about that I have to watch out for. Now I'm going to come back to the emergency department because now maybe whatever disease state that was not diagnosed the first visit now is declaring itself again that potentially we might need to work up a little bit better. So I think that's actually a really great overview.
Yeah, and Jan made a point of this on MREP just recently is when people get their lab results in my chart. Well, they say, oh, they came back fine. They've ruled out heart attack or whatever,
Yeah.
right? Well, in the end, you and I know that that is not the case necessarily. I mean, it's better than if they're abnormal as us being patients or family members or friends, whatever. In the same way, they do these jury perception studies where they interview the jury after a medical legal action. And sometimes they interview the family members after one of these actions. And so frequently, the question is, why didn't you go back to the ED? And the answer is simply, I was already there. They did all the tests. They told me everything was fine. Now, you and I know that we never tell someone everything is fine, even for like a x-ray, right? We didn't see a fracture. It's unlikely there's a fracture, but it doesn't mean for sure there isn't. I mean, hips are notorious for that, right? In that same way, the patient needs to understand, and just maybe broken record to what I said a second ago, is that if there is still some diagnostic uncertainty when the patient leaves, that needs to be reflected in your documentation, that the patient understands that and agrees and understands that you haven't ruled out everything. And if their symptoms progress or don't resolve or worsen or change, they need to come back.
Absolutely. No, I think that's actually a fantastic overview. Now, Mike, as time is running short, I do this with every single one of my guests and I ask them, hey, if I'm a first time listener, what are the 3 key big takeaways that I could take away from this episode?
So the first thing is a phrase that I've said in the past, and I think I said it earlier today, is where we get most of our information is from our initial contact with the patient with the history. A good history is free. A poor history could be very expensive. This is our bang for the buck. And some literature shows between 87 and 92% of the time, so maybe 90% of the time, we can either make a diagnosis or drastically narrow that down just from the history alone. The second point is something we really haven't talked about a lot, which is the exam. And so frequently, I see a patient with neuro symptoms, whether that's dizziness or fatigue or numbness or confusion or incontinence or back pain or all these different things. And there's really no adequate neuro exam. And it drives me a little bit crazy with my residents and my students, not just here, but other places, and also looking at charts. And it's not even the residents, it's attendings too, that the neuro exam is this across the room neuro exam where, cranial nerves normal as tested. In other words, I just did a neuro exam on you, my friend. It's normal. But, probably not the exam that you'd want for a family member, right?
Yep.
So, look, you're not going to frequently find a problem, but when you do, it could be super, super important. Like the example we gave earlier of the 5-year-old who had the midline surgical scar. That was a game changing finding. And then the third thing is really just reiterating what we talked about a second ago. If a patient does leave with diagnostic uncertainty, which is frequent, they need to understand when they should return, and they should feel welcome if they are a bounce back patient, that they're not inconveniencing us, more that they're giving us another chance to make that diagnosis.
Absolutely. And I love the way that you just framed that. As opposed to blaming ourselves, we can reshift that perspective and just ask ourselves, hey, was there something that we could have done a little bit better the first time around that we can now address with this patient? Is there something different that I need to do from my history standpoint? Does my exam need to be even more thorough than what happened the first visit? So I think that's actually really, really valuable. Mike, is there any place on social media where folks could reach out to you, connect with you if they have any questions about bounce backs and how they can become better clinicians by understanding this?
Sure. Folks can go to my website. It's like emergency medicine. So embouncebacks.com. And it's all one word, embouncebacks.com. And not only will you be able to contact me through that site, but additionally, there's a lot of backstory. So folks that are interested in some of these medical legal cases, especially the second of the 4 books, the medical legal, Bounceback's medical legal, we just came out with a new edition earlier this year, 2025. Well, there's the backstory behind some of these cases as well. In the book, we have part of the opening statement. You can read the entire hour-long opening statement. So for folks who are losers like myself who want to spend their time reading entire hour-long opening statements, you can see that on this site. And it's really astounding because it's not something that is accessible really anywhere, is some of this trial testimony. So there are some, folks, MedMal Reviewer does this, and there's some other sites where we look at some of these things, but it's very, very difficult to find actual trial testimony or deposition testimony just on the internet.
Definitely. And your Bounce Back series has been such a valuable resource. And I've recommended that to every single resident that I've worked with that's interested in trying to understand the concepts that we've talked about throughout this episode. So what I'll do is I'll actually link your website on the show notes. So for anybody that's interested, I would highly, highly recommend this. Now, as an outro, bounce backs have a way of staying with us. They replay in our minds, they challenge our confidence, and they force us to sit with uncertainty. But as we talked about today, they're not markers of failure. They're actually markers of complexity. They remind us that good emergency care isn't about being right every time. It's about judgment under pressure, communication under uncertainty, and humility in the face of imperfect systems. If there's one takeaway from today, it's this: you can't prevent every bounce back, but you can most certainly learn from every one of them. So this week, take one return visit, look at it differently, ask what influenced the decision-making in the moment, talk about it openly with a resident or a colleague, focus on the process, not the outcome. Because when we treat bounce backs as feedback instead of blame, they become some of our most powerful teachers. Thank you again to Dr. Michael Weinstock for sharing his insight and helping us reframe how we think about these cases. If you found this episode helpful, follow the show, leave a quick review, or share it with someone you teach or work alongside. Until next time, stay curious, stay reflective, and keep learning.